Good afternoon and welcome to our Learn and Share conference call. I'm Russ Derry, Director of Education for Epilepsy Foundation of Michigan, and I'll be moderating this discussion. The topic for today is navigating and improving our system of epilepsy care. And we're pleased to have as our speaker Dr. Chloe Hill, who's an epileptologist with Michigan Medicine. Dr. Hill, could you briefly introduce yourself, talk a bit about your clinical and research interests, and describe your experience with this topic?
Certainly. First of all, I want to say thank you so much for inviting me to speak with you today. I'm really excited about this topic, and this is a wonderful forum to explore these complicated and important issues. So I'm currently an assistant professor of neurology at the University of Michigan. I did my training in neurology and epilepsy at the University of Pennsylvania. And while I was there, I completed a master's in health policy research with a focus in quality improvement and patient safety. So these are all issues I'm very much interested in. I came to Michigan about 2 years ago, and here I have a clinical focus on the care of adults with epilepsy, and I tend to see also women with epilepsy who are thinking about women's issues in pregnancy, and also see patients who are interested in surgical treatment of epilepsy. But I'm fortunate to see a wide range of patients with various diagnoses and needs, all within epilepsy. So I spend the majority of my time actually as a health services researcher. And my passion is understanding how we can improve care delivery for people with epilepsy. And so I think a lot about sort of the classic issues we think of in health services research of access to care, value of care, and the cost of care, and thinking about how we need to balance these things against each other and improve these things for our patients. And I'll get into some more of my specifics of things that I've been working on throughout this call, but that's sort of broadly my interest. And I'm excited for this conversation.
Okay, great. And sounds like we have the perfect speaker for this topic. So the U.S. healthcare system is the most expensive and quite possibly the most complex healthcare system in the world. We spend more per capita on healthcare than any other developed nation. And this includes higher drug prices, higher administration costs, and higher prices for medical services. Despite this, Americans have worse health outcomes than other developed nations, including lower life expectancy, higher infant mortality, higher suicide and avoidable death rates, higher obesity rates, higher chronic disease burden. We also have fewer physicians and visit the doctor less frequently. Now, we do excel in some areas, such as flu vaccination rates, breast cancer screening and prevention, and availability of advanced diagnostic and treatment options. But overall, increased expenditures in healthcare are not resulting in improved health outcomes relative to other developed nations. So many aspects of our overall healthcare system impact the quality and cost of epilepsy care. But there's also a number of factors unique to our system of epilepsy care that influence patient outcomes. So today we'll discuss the structure and functioning of our epilepsy care system, what works well, what can be improved, and how patients and families can effectively navigate the system and access appropriate care. So let's start by reviewing how the quality of epilepsy care can be defined and measured. What are some of the currently available measures and indicators of quality care? And to what extent are we actually measuring epilepsy care quality in the U.S.?
This is a great question, and I want to start a little bit bigger picture and then narrow in on this topic, because I really liked your introduction about the challenges of our healthcare system in the U.S. And I do agree, by many metrics, we are not measuring up the way we're supposed to, largely because we spend so much on healthcare. And as we know, we spend a huge amount of the GDP, about 20% of our GDP on healthcare. And the real question is value. I think we would be more comfortable spending a lot if we felt we were getting good value for our purchase. And the only way really to unpack value is to think about that equation of the quality of care divided by cost. So before we can think about value and understand if we're getting, good product for our financial investment or economic investment, we really need to delve into quality. So I thought that was a perfect intro. So let's talk about quality. So quality is really important. It's sort of our gut feeling is we want quality. Quality of healthcare is obviously a high priority, but it's really hard to unpack in many ways. So, just even developing a consensus for what we consider to be high quality care can be challenging, particularly across heterogeneous populations such as people with seizures and people with epilepsy. And then even once we can sort of reach a consensus on what elements of care are important for high quality epilepsy care, sort of nailing down those elements into things that we can quantify, measure, and track over time becomes incredibly difficult. Even if we have a quality metric that we all believe is really important, if we can't measure it, if we can't assess our performance, then it's not really a helpful metric. I think, in our field, we're very lucky. We've had a lot of advancement in the thinking about quality care in epilepsy. The American Academy of Neurology has several metrics, which we'll get into the details of, which are continually revisited every few years and sort of honed and improved as we think more about the concept of quality care for patients with epilepsy and the practical logistics of how to measure this. So they were most recently updated in 2017, and I think are again under review currently. Just going to review what those metrics were to be explicit before we delve into them a little bit more. So one metric is counseling for women of childbearing potential with epilepsy, and that involves several elements, including discussion of folic acid supplementation for all women with reproductive potential to decrease the risk of neural tube defects, and talking about potential interactions between anti-seizure medications and conception and types of contraception, and also thinking about the potential teratogenic impact of the medications that we use on a developing fetus. So there's a lot sort of in that metric, but that's an important metric and one that has persisted throughout the years. Another metric is referral to a comprehensive epilepsy center or discussion of referral to a comprehensive epilepsy center for patients with intractable or refractory epilepsy. And so that's sort of highlighting the need for patients who have uncontrolled seizures to get a more comprehensive evaluation to make sure that diagnosis is correct and to have the opportunity to access sort of more advanced or perhaps even invasive methods for treating seizures. Quality of life has become increasingly prioritized as it should be in how we think and care for people with epilepsy. And so there's actually two outcomes related to that. One is a quality of life assessment, and the second is actually looking at the quality of life assessment over time to see if we are moving patients' quality of life in the right direction in our care for epilepsy. There's screening for depression and anxiety, which are really important comorbidities in the population of patients with seizures and epilepsy. We know that depression and anxiety impact probably there's a range of measurements, but we'll say about a third of patients with epilepsy, and it's particularly important for us to consider because it is treatable, and there's a complex interplay, which you could have a whole session on, and you probably do, about the relationship of mood disorders and seizures. But the bottom line is, if you work to treat both components of a patient's illness, there's sort of a synergy and everything improves. And then lastly, there's a sort of basic measure of documentation of seizure frequency. And that's obviously critical to how we think about treating epilepsy and how we provide epilepsy care, which our primary goal, although one of many, is to improve seizure frequency. And so making sure that we are nailing down that very concretely when we see patients and when we care for them. So these are, I think it's total 6 measures, and these came out in 2017. And it's been interesting to see, how these can be used, how they can be measured, and what they mean. So there's many sort of obvious challenges with these, but I'm just going to say them out loud because I think they're of interest. So the first is, how do we measure these? So the standard is really to document as a provider. If I were seeing a patient, I would sort of document that I touched on these different points with a patient. And, that's the first step of doing this, but it could document something that wasn't necessarily delivered. Just because you said it didn't mean it was communicated clearly. And there's interesting studies of providers and patients in which it's very clear that what a provider thought they communicated or intended to communicate really didn't come across at all to the patient, or the patient had a different experience of what was part of that encounter. So, looking at documentation isn't perfect, but it's one way we can measure this. And then, once it's documented in the chart, we have to think about how we can abstract it, how we can sort of measure that in a way that we can quantify it and follow it over time. And that's not easy. Our medical records have made many advances in that we now have them electronically, so they're easier to query than paper charts, but it's still laborious to pull out records, to pull out data from an electronic medical record. So these are areas where we're hoping for advancement in the near future. And the other point I want to make, in the many points I can make about this, is, it's also important to know that these quality metrics are grounded in evidence, but also expert consensus. And there's a growing body of literature, not large, but growing, really assessing how important these quality metrics are. So in particular, there's been studies to see, do these quality metrics, does adherence to these quality metrics associate with improved clinical outcomes? And there's been a very few studies that suggest that, yes, when we adhere to these metrics, we do see an association with improved seizure frequency. But I think that's an area under further development, which is really important to make sure that we're sort of prioritizing the right things. The last challenge I want to mention, because it's inherent in sort of the in this topic and how this can be sometimes fraught when we talk about quality metrics, is the potential for these to be linked to reimbursement. And so currently, when we look at these epilepsy quality metrics, they aren't linked to the reimbursement to the providers, but in many other fields, many of the quality metrics are. So we have to always consider that element as well as we move towards value-based purchasing and reimbursement for quality of care, that when we develop metrics, we need to be thoughtful about what we're measuring and also consider the potential repercussions, such as how these metrics can be linked to reimbursement.
Right. And from a patient perspective, is it helpful for patients to know what these quality metrics are so that if they realize that their doctor isn't asking them about depression and anxiety or isn't discussing, childbearing issues, if they're considering or in that age range, is it something that is helpful for a patient to be able to bring that up to their doctor or consider that if they find that their doctor is not attending to those quality measures?
So that's a great question. The way these measures are developed and disseminated is really to providers. However, the development group does have input from patients and care providers. And so this is meant to encompass multiple perspectives when we develop these metrics. Now, I hate to off-shoulder responsibility as a provider to my patients. Your neurologist or the doctor who's providing your epilepsy care, seizure care, really should know these elements of care and should be providing these. But every patient benefits from being proactive and being an advocate for their own health and for their own care. And so I think that's a really great point, that as from the patient side, if patients are aware of how we've defined quality, what's considered appropriate or high quality care, and thinking about, have those elements been covered in my visit? Do I have questions about those things? I think that's a really great way to assure comprehensive and high-quality care in an epilepsy visit.
Great. And I don't know if you are involved at all in American Academy of Neurology, but one thing my personal thing that I would like to see included, and I think it was included under the umbrella of behavioral health in the last version, would be the whole aspect of cognitive function, which in our needs assessments that we've done is right up there with depression and seizures as having the largest impact on quality of life. So I would love to see something in those quality guidelines about discussion of the impact of epilepsy and anti-seizure medications on cognitive function.
Yeah, so that's a great point. In the prior set that I can't remember when they were, maybe 2014, I may be off on that, there was a more specific quality metric querying about side effects, which I think intended to get at that. And I agree with you. I think that's a huge element of care that we need to prioritize if we're thinking about ways to improve, to align our care with patient priorities and to improve the quality of care. Interestingly, the metric for querying side effects, I think, was retired because it was considered to be so universally adhered to that it no longer needed to be explicitly a metric, which is another odd thing about quality metrics in the field of quality. The other thing, so I'm not personally on the committee that develops these metrics, so I hope to be in the future, but they're circulated among a wide range of providers for input, and it's very interesting that even among very established, sophisticated, experienced epileptologists, we can't always agree on what should be prioritized in these metrics. And I have seen a lot of feedback saying that, cognitive function and cognitive health really needs to be spelled out here. And I'm hoping that'll be more prominent and more explicit in future iterations.
Okay, great. So the International League Against Epilepsy lists 150 clinical practice guidelines and reports related to epilepsy. What are clinical practice guidelines? What's the role of these guidelines in promoting quality epilepsy care? And how consistently are key guidelines being followed across our epilepsy care system?
So this is another great question. So I went to the International League Against Epilepsy website to see what all was listed in here, because I can think of a handful of guidelines that I use regularly, but certainly not 150. And the interesting thing is it's a wide range. So, there are certainly some documents that are considered clinical guidelines, and then there's some other documents that are considered sort of definitions or consensus statements, and they're all a little bit different depending on largely the level of evidence that supports the recommendations. But in general, these are incredibly useful, and I think a big step in standardizing our approach to treating epilepsy and seizures. And the point, obviously, of standardizing is to make sure that we're using care that's grounded in evidence. So I would say probably my favorite example of guidelines is the first seizure guidelines from the AAN, or American Academy of Neurology, because these really spell out very clearly our approach to a patient who has a first seizure, when we're trying to assess at that point whether or not this represents epilepsy or continued risk of subsequent seizures versus a first seizure, because we know about 1 in 10 people in the population will have a single seizure in their lifetime. And the reason I like this guideline is because it's very clear, it's pretty practical, and it's fairly broadly used. So one of the challenges of these guidelines is there are so many, and there's so many different groups that promote guidelines. So there's obviously the International League Against Epilepsy, the American Epilepsy Society, the American Academy of Neurology, there's the American Clinical Neurophysiology Society, and many, many more. So what happens sometimes is that the literature gets muddied, for lack of a better word, by many guidelines that may not all say the exact same thing, or guidelines and consensus statements. I think this can be particularly challenging in some areas where we would do better to universally follow the same set of guidelines. So not to be too tangential, because we're not so much focusing on the inpatient and acute setting, but this comes to light with the status epilepticus guidelines, which are commonly used, but there are many, many out there. And I think that we're starting to understand that there's some breakdown in adherence to optimal care. In this example, we've seen it, and I'm sure it's true in other examples, in the treatment of status epilepticus, because there are so many guidelines and sort of leads to a lack of consistency or lack of consensus in how to treat patients. Other guidelines that I think are particularly helpful are the ILAE, or International League Against Epilepsy, has some guidelines about how to treat epilepsy and seizures in pregnancy, and those are pretty broadly disseminated and very useful. Defining drug-resistant epilepsy, which was published, I think, in 2010, so a while back, but really changed our conception of when to escalate care, and that it was a very useful definition. So there are many useful documents out there. I would like to see sort of even more consensus, even more unification. But, we can only do when it comes to guidelines, we can only create what the evidence supports, and we can't, create guidelines that are firm if we don't have evidence for that. So to back that up a step, we need to be doing the studies and the research to understand how to best treat these challenging elements of epilepsy care.
Right. Great. So we'll discuss different aspects of epilepsy care in more detail, but can you start by giving us an overview of some of the biggest strengths and weaknesses of our system of epilepsy care as you see it?
Sure. So, one thing, again, going back to the challenges of the U.S. healthcare system, which apply to epilepsy, one thing we're incredibly fortunate to have is just a wealth of technologies to aid in how we diagnose and manage epilepsy, and really a huge amount of expertise. In some of my work, I've studied the use of long-term EEG monitoring when we care for patients in the hospital, and thinking about how that supports high-quality care and access to that technology, which my personal bias is we still have to hugely improve that in the United States. But, that resource is scarce internationally. So, even what we feel like we can't supply at appropriate volume, or this is a limited resource in our country, is still such an advantage in our ability to diagnose and treat patients. I think that's also true with, we think of the surgical treatment of epilepsy, that's really just developing very quickly every year, with more options and more expertise, and having a range of types of surgical approaches within reach at many, many centers throughout the United States is a huge strength. And I also think about all the anti-seizure medications that we have available. So we probably have over 20 now that are available to use. And, we'll talk about this too. Sometimes a hurdle or two to get for our patients, but are pretty available compared to a lot of, third world countries where there's one or two options. So, the sort of the wealth and availability of technologies and resources is tremendous. And by some measures, we are doing well pairing patients with expertise. So some of my work is looking at administrative claims data, which is it's helpful because it's large populations, often nationally representative, looking at insurance claims to summarize very high level what's happening with patients. And when we look at that data, we do see that the majority of patients with epilepsy are seen by neurologists, perhaps not regularly enough, perhaps they don't have the expertise in epilepsy, but it seems about 70% of patients with epilepsy are seen by neurologists. So, by some measures, patients are getting to where they need to be for an expert treatment. However, that analysis does not look at the delays. And so there are long delays to diagnosis and to specialized care. And this is probably best. So now I'm switching gears into weaknesses. So delays is a big problem. So it's probably best characterized, best measured when we look at the surgical treatment of epilepsy for patients with refractory epilepsy. And in that cohort, what's been described is about a 10-year delay often from initial seizure to diagnosis of epilepsy. And then another about 10-year delay from that diagnosis of epilepsy to undergoing epilepsy surgery. We're talking about a 20-year delay here. So that is really disheartening. And it also has not improved that much over the last 20 years. So that's certainly a place that we need to advance how we're caring for patients. There's also a lot of disparities in our in access to care, and that's seen in geographic disparities, regional differences in availability of neurologists and availability of expertise, socioeconomic disparities, and disparities in insurance status, which is a huge impact on obviously access to care. And then, I will say that sort of two other points, although I can go on and on because I think there's many places we could do better. I think we currently have insufficient care for epilepsy for sure. We need better anti-seizure treatments with fewer side effects. We need better means for patients to have the ability to predict when they're going to have seizures so that they can modify their their lives appropriately at those times and detect seizures. But we're also really lacking in the rest of the support required to care for patients with epilepsy and with seizures. And particularly, I think about the mood disorders and the cognitive impact of epilepsy, where we really are falling short in our ability to offer care and support to patients.
Okay, so let's talk about start by talking about diagnosis and treatment initiation. So what are some of the systemic factors that currently contribute to misdiagnosis, incomplete or delayed diagnosis, and inappropriate initial treatment? And what could be done to reduce some of these problems?
So this is a great topic, and it's a difficult one. So, but very much worth attention. So, the first point is that seizures are hard to diagnose. They're quite different than other conditions that we could give it as an analogy, such as diabetes, where it's diagnosed by a pretty straightforward blood test. We don't have any type of blood test for seizures, obviously. Really, the only definitive test is if the patient has an episode and they have EEG leads on their head during the time of that episode, then we could capture it and diagnose it with 100% certainty. And often there's clinical factors that give us a feeling of having 100% certainty even without the EEG. But it's hard. We don't have the concrete ability to diagnose all patients who have this condition the way we do with other types of illnesses or diseases. What we use is a sort of a clinical expertise, and I think that is the answer to to why there is so much delay and why there is so much misdiagnosis, because there isn't a straightforward test, aside from EEG, which often can give us an answer in the right setting. It really relies on a high level of clinical expertise to be able to put all the pieces together. When I see a new patient, I have the luxury of having an hour to get to know someone, and I take a history that starts from before they were born and goes all the way through the current time. And I really rely on, reviewing all that information, all the data that exists, and then using my experience to put together the sort of presentation, the clinical symptoms, the brain imaging findings, EEG findings, putting it all together, making a diagnosis. And I may not always be right, obviously, but it's a complex diagnosis. And so often, not always, sometimes there's a classic presentation, but not uncommonly, a very high-level expertise is needed to put it all together in our current, in where we are right now in diagnosing epilepsy. I hope someday we have a simple test, but we don't have it yet. And so, that means that we're limited by access to expertise. And so I think my sort of the best answer I can give is limited access to expertise is a challenge. And so, there's a couple components to that. So if we think about access is a really interesting topic because it breaks down into so many different subtopics. So the classic one we think about is insurance status and having the ability to pay for care as being critical to access, which it absolutely is. But there's other elements such as accessibility of care. So if you live very far away from the specialist you need, it's going to be hard to access even if you have insurance. And availability of care. So even if you, live right near a comprehensive epilepsy care center and you have insurance, but they have a 3-month wait list, there's a supply problem. So all these things are elements of access that are important to consider. And so I think, things that are more actionable would be thinking on sort of an advocacy policy level and improving insurance coverage for patients with for patients in general, so that they can see and afford the care that they need. And thinking about more innovative methods, which we'll get to shortly, of accessing subspecialists. And then there's also sort of the really hard to implement but basic concept or basic recommendation of improving more broad comfort with and experience with diagnosing neurologic problems. So, a lot of patients, I might even say most patients, don't see a neurologist right off the bat. They see a primary care doctor or an ER physician. And so as best we can improve education among these providers about the various ways seizures can manifest, that would be, help us tremendously in decreasing delays and misdiagnosis. But that's, that's a big hurdle. There's also sort of interesting and maybe more complex, but hopefully available in the future, ways to answer this. So, for example, I am working with a group that's looking at patterns of care of patients who are ultimately diagnosed with seizures, and looking at if there's sort of a signature or a pattern of care that could be tracked either using claims data or EMR data that sort of highlights a patient that is likely to develop epilepsy. So to give a concrete example, I've read a couple papers in which it's been noted that patients with epilepsy often have higher utilization of psychiatric care or medication or receive a psychiatric diagnosis up to 6 years prior to their epilepsy diagnosis. So it is possible that as we sort of better understand the epilepsy process and hone our ability to analyze big data, that we may be able to sort of identify these automated patterns identified automated methods to identify patients earlier through review of their healthcare utilization, which is sort of new approach, but I think has a lot of potential. It may be very helpful down the line.
Wow, yeah, that's fascinating, and you can imagine that being used for a lot of different potential precursors to epilepsy, like traumatic brain injury or stroke or things along those lines as well. So, great. So a significant problem with epilepsy, and we've alluded to this already with epilepsy care, is the delay in referring those with drug-resistant epilepsy to subspecialty care. So in short, if two appropriate and well-tolerated medication trials or 12 months of seeing a general neurologist have failed to bring your seizures under full control, you most likely have drug-resistant epilepsy and should see an epileptologist at a comprehensive epilepsy center. Too often, though, patients stay with a general neurologist or primary care physician well beyond this point, in some cases having tried many medications over many years and never being referred to a subspecialty care. So can you talk about the impact of such delays on patient outcomes and healthcare costs, and why these delays occur, and then what can be done to reduce them?
Okay, so this is the money question, and I wish I knew the answer to this. This is a topic of my own research that I spend a lot of time thinking about and working through. And, you know, the couple-word answer is it's multifactorial, of course. But, you know, the question is to delve into that, to understand the different factors that are involved, and you know, of more interest to figure out where we have leverage to improve this is just so critical. So absolutely, you know, the recommendations for when to refer a patient for an escalation in their evaluation are pretty clear. And, you know, the definition of refractory epilepsy has changed over the years. But in recent years, it's I think, pretty clear when it's appropriate for someone to be referred for evaluation. However, I will say that I don't know that these recommendations reach the broad audience. I think these recommendations are well known by people who see epilepsy patients frequently, and I do wonder the uptake more broadly among neurologists, and certainly I wouldn't expect primary care doctors to necessarily know these recommendations. So I think, you know, part of it may be an issue with dissemination of these recommendations. But to take a step back, so when I say this is multifactorial, there's obviously many elements that are involved. So there's from the patient side, the provider side, sort of the health system side, and then geographic factors. And I think all of these are involved. And we have to try to unpack this. Some work has been done specifically regarding referral for epilepsy surgery, and that's where a lot of my background knowledge comes from. So to talk through that a little bit, it's a very concrete example of when patients meet criteria for refractory epilepsy or drug-resistant epilepsy, and that would be the time for referral to a comprehensive epilepsy center. But what we find when we look at the data, which is, it's a hard thing to measure, but it's been measured sort of in various data sets. And I'm actually looking at this right now using a Medicare data set. Probably only about a tenth of patients are referred to consider surgery at that point. Now that's a more specific question than being referred to an epilepsy center, but we know that number is way lower than it should be. I'm sorry, I should have said 10% of patients with refractory epilepsy, so of patients who would warrant evaluation for surgery. But that number is probably, it's certainly not all patients with refractory epilepsy being referred to a comprehensive epilepsy center, even if we're looking beyond the question of surgery. So we know this is a problem, and we also know that it doesn't appear to be improving over time. And so the question is why. And to try to unpack that a little bit, some studies have been done looking at these various elements. A lot of the focus has been on the provider, which I think is appropriate if your neurologist doesn't suggest referrals to an epilepsy to a comprehensive epilepsy center, it would be rare, not impossible, but a rare patient to refer themselves. And I think there's a variety of reasons for which this can break down at the provider level. I think sometimes both patients and providers have a sense that things are stable. So, seizures aren't under control, but things feel stable, and that may seem good enough. People are incredibly resilient and can tolerate a lot of adversity, and I think honestly sometimes people get used to having seizures, and it leads to probably some complacency from the provider perspective, because things seem stable and they feel like they're not getting worse, even when patients continue to have seizures and side effects. And I do think that's a big part of this. I think that there's also sometimes, and I don't mean to incriminate providers, but I do think this plays into things, a tension in which a provider refers their patients to a comprehensive epilepsy center for evaluation, and they never come back. And maybe that's appropriate. It's hard for me to say what's the right path for that patient. But often, if that's the recurrent experience of a patient, a provider who refers their patient doesn't hear back from the comprehensive epilepsy center, doesn't see the patient back, that's a really unsatisfying experience. Conversely, I think that, or not, I shouldn't say conversely, but another option is the provider has referred patients previously, and the patient didn't have a good experience or didn't have a good outcome. So there's many other components there, but that's sort of one component. There are geographic factors, obviously. So there are about 230 comprehensive epilepsy centers, level 3 and level 4, that are accredited by the National Association of Epilepsy Centers, and that's a lot. And in many areas, they're densely available, such as in Southeast Michigan. But, there's states that don't have an epilepsy center or that have one. And so geographic factors can be a true limitation in the evaluation of patients with epilepsy. We're getting better at thinking about remote or in-home options for evaluation, but sort of our fundamental to our care is an inpatient evaluation, and that can be very difficult for patients who live far away from comprehensive epilepsy centers. And then I think there's sort of health system factors, which we touched on. I won't belabor again, but thinking about access from an insurance standpoint and barriers as far as delays to availability in a comprehensive epilepsy center. And then there are issues or challenges on the patient side, which I personally haven't investigated as much, so I don't have much to say on this, except that I think patients are understandably at times reluctant to meet yet another provider and sort of start over in their relationship, even to see a specialist. And often this conversation happens around the time of the mention of surgery for epilepsy treatment, which is certainly one element of what a comprehensive epilepsy center offers, but is far from the only element that's being offered. And for those, most people know that it would be many steps down the line past that initial evaluation. But I do think for many who hear that, it's unappealing, maybe even shocking, and so that may be a reason for a patient to actually say, no, I'm not interested in that referral or that evaluation. So those are some of the many, I only touched on a few, many factors that are involved in this very complex issue. As far as the impact of delays on patient outcomes and healthcare costs, this is very hard to measure. So I will say that when we try to look at this as far as patients referred versus patients who aren't, it is confounded by who is referred. So to give an explicit example that I hope give some clarity to what I just said, we did a study looking at early referral to neurologists. So now this is a different question, I admit. So I'm taking a step back from referral from a neurologist to an epileptologist, but just looking at early referral to a neurologist as opposed to continued care with a non-neurologist for patients with incident epilepsy, so it's with a new diagnosis of epilepsy. And we looked at this, we asked this question of an administrative claims data set from United Healthcare, and just tried to assess matching patients who had a new diagnosis of epilepsy who weren't seen by a neurologist to those who were seen by a neurologist, and looking at their trajectory over time with attention to healthcare utilization, costs of care, and some of the quality metrics that we could measure. And you shouldn't go into any research project biased, but we all like to think that we're providing some value, we're providing some benefit when patients come to us as specialists. And we were somewhat surprised to see that when we looked at this question, which again is a little bit different from the question that you asked me, but just to bring it up as an example, what we found was that patients who were referred to see neurologists actually ended up in the years subsequent to seeing the neurologist using more health care, having greater expenses for health care. Although they did meet some of the quality, they were more likely to meet the epilepsy quality metrics that we spelled out. But we did think that was likely confounded, although we can't say. There's always a possibility that we're providing more expensive care with no benefit. But we thought that was likely confounded because as best we could measure it, these patients were just sicker overall who were referred to neurologists. So that's sort of the selection bias and referral that's complicated. So this is a really long way to say that it's hard to measure how it's hard to measure the benefit of seeing an epileptologist as opposed to staying with a general neurologist because there is some bias in that usually patients who are referred are have more severe epilepsy or more severe disease. I will say there was a study that was published by Natalie Jeté and Sam Weeb's group last year, I think in JAMA Neurology, that was kind of eye-opening, that looked at patients in Canada who were referred to a comprehensive epilepsy center or seen by a neurologist at a comprehensive epilepsy center, and they actually showed a decreased risk of mortality over time. I can't remember how many years for patients who were seen at an epilepsy center as opposed to those who weren't. I think it's an imperfect study, but it also suggests that there is measurable benefit to being seen by specialists early on. And I will say, I guess my first answer is what can I tell you from the literature, which is important, but also anecdotal experience is important. So, we all have very frequent experiences of people who we see had delays in their care, and it really impacted them in their own lives. So we don't necessarily know that delayed treatment after the first seizure, delayed initiation of anti-seizure medication impacts prognosis. In fact, there's data that suggest it doesn't. But we certainly think that the delayed treatment after many seizures could impact the ability to effectively treat seizures. And so that's a concern. We certainly see patients who had a huge amount of testing that may not have been needed or prescriptions that were likely inappropriate in retrospect due to delayed diagnosis. And there's also risk of harm to a patient who, perhaps wasn't counseled appropriately on the risk of driving or swimming. Certainly psychological harm from ongoing seizures without proper diagnosis. There's social implications, perhaps relating to job or economic implications. So anecdotally, I think it's very clear that the delay is very harmful, even when we find it even when we find it difficult to measure in our research studies. So to just sort of sum up in the last point, what can be done about them? So I wish I knew better how to fix this, and this is exactly what I'm interested in. I do think that there's And again, I hate as a physician to be passing the burden to patients and their families, but patient and family advocacy for their own care and for specialist care is incredibly effective. And I think that patients should feel empowered to do that if they feel that they need, either escalation of care or second opinion. It's a very smart and effective thing to do, to suggest being seen by a specialist. I think that the advocacy that's in education that's done through programs like the Epilepsy Foundation plays a huge role in this as well, and then that's a real way to make a difference.
Right. And that's certainly been a major focus of ours. We certainly get many calls from people who never heard that there was such a thing as an epileptologist or a comprehensive epilepsy center, who've been, like I said, treated for years with a general neurologist and tried 10 plus medications. And so we certainly feel like we can play a huge role in helping with that. But yeah, there's so many complicating factors, like you said, healthcare costs being one, because, if you're referred to a comprehensive epilepsy center, you may end up getting surgery. You may end up having all kinds of expensive tests as part of that pre-surgical evaluation, so that those initial healthcare costs may seem higher than if you weren't referred, but the long-term costs may be lower. So it's so many complicating factors, but you gave a great overview of the issue and some of the potential ways we can address it. So another thing you alluded to is that in Michigan, a significant portion of the population lives two or more hours away from a comprehensive epilepsy center. So can you discuss what you've learned from your use of telemedicine during the pandemic and how it can be used going forward to improve access to subspecialty care for those who are in rural and remote areas?
Yeah, it's a great question. So I hope I won't offend anyone by saying this, but to me, if there was any silver lining to COVID, which clearly has very few, if any, but from my perspective as a healthcare provider, I feel like the movement towards telemedicine and embracing of telemedicine has just been hugely advantageous for the care I'm able to provide for my patients. So this was previously sort of spoken about as a priority, but severely limited by reimbursement constraints. And I think provider discomfort with change and innovation. But practically overnight, we had few, if no other options, and so there was a massive movement towards telemedicine. And it's just, I think, has been a huge boon to our care. So, there's several barriers specific to patients with epilepsy, such as challenges with transportation, that I think this has greatly overcome. And so I've been really pleased by that in particular. And in my experience, I've just been pleasantly surprised by how effective evaluation over video or by phone is. And I think for the most part, patients are feeling similarly. There's been a couple surveys published of patients, and people for the most part are happy with their care that's being provided via telemedicine or telehealth, although I'd be really happy to learn more about the patient perspective. There are some challenges. So obviously there's some critical tests for which we don't have a great remote option, such as if we want to do an inpatient EEG evaluation and collect some data on seizures. But I will say that there's also sort of been a simultaneous push to do more ambulatory in-home EEG monitoring with video, which is a very powerful diagnostic test and is allowing us to do more remote assessments. The other thing I am keeping an eye on is, we think about telemedicine right now perhaps breaking down some barriers to care, certainly geographic barriers, in a way that could be hugely beneficial to our patients. But we also have to be thoughtful about if we could possibly be perpetuating disparities. So I just worked on this with a group here, looking at use of video versus phone visits. And there seems to be, not surprisingly, certain patient populations, specifically those who are older or those who don't have adequate broadband access, who are unable to participate in video visits and need to use phone visits for telehealth. So we have to keep an eye on that moving forward. I think that's going to be an important policy issue, such that if we continue to move forward with telehealth, which I'm wholeheartedly hoping we will, we don't get to a point where phone visits are not reimbursed, because I think that could introduce new disparities in access.
That's a great point, yeah. So how is our current supply of epileptologists compared to demand? Are we seeing any trends in the number of physicians going into neurology or completing epilepsy fellowships?
This is an interesting question. So I don't have numbers in my head for epileptologists, but I'll tell you the trend with the neurology workforce in general. So about 10 years ago, there was a formal assessment of the neurology workforce through the AN that suggested that around that time we had a 10% shortfall in neurologist supply, and it was anticipated to be about a 20% shortfall by where we are now in time. And interestingly, the field was able to step it up a bit. So spots at neurology residencies increased, and there's been a huge increase in the non-physician workforce. And it's a recent assessment I haven't seen published yet, but I've heard about. It seems that gap is actually closing rather than growing. So I think that this call to action was heard, and things are moving in the right direction broadly for the neurology workforce, although I have not seen the numbers on the epilepsy-specific workforce. And we do know that this is far from imperfect. So as I mentioned, there's regional variation in access to comprehensive epilepsy centers. Some of our work has shown pretty impressive regional variation in the density of neurologists, and so that can hugely impact access to neurologists. And certainly, even in an area that we know is dense with epilepsy centers and epileptologists such as our region, it can take a surprisingly long time to see an epileptologist. So even if things are moving in the right direction, I don't think that there's evidence that we are where we need to be yet.
Right, and related to that, you mentioned waiting times sometimes being 3 months, 6 months, even longer times to see an epileptologist. Do you have any tips to help people get an appointment sooner, whether it's a first-time referral or someone seeking a second opinion?
Great question. So I have two that I would suggest. And I'd love to hear if other people have better ways to do this. So one I would say is, like, if you're thinking about a referral but you're not certain yet, just schedule it, because I think a lot of times people start having the conversation and they think, oh, maybe I'll just try one more medicine, or I'll just wait another 6 months and see if things get better. But that's 6 months that you could be on a wait list or be getting something on the calendar. So I would just, sort of, if it pops into your head as something you might be interested in, move forward with it. And then I would also say that this is my very specific perspective, but if you're looking at seeing an epileptologist, consider going to the satellite locations beyond the main campus. So I have an experience in that. I work at the University of Michigan. Obviously, our main campus is in Ann Arbor, but I see patients in Brighton. And I think a lot of patients feel to see the experts they need to be seen in Ann Arbor, even though I'm the same physician, traveling to a satellite clinic, and people can get in with me much, much sooner, like months sooner, if they see me in Brighton. Now, I'm not saying that you should go to, another location and see a non-specialist, but just maybe when making the appointment, ask some follow-up questions to see if you can see someone who is that expert in that specialty, but at a different location you can often get in sooner. And then the last point that I would make is to just, even doing all these things, it may still take some time to get in. And then from the patient and family side, and I think I know I'm like preaching to the choir because people on this call are going to be very savvy, but to make sure that you make that visit as high yield as possible, and specifically bring all the records that might be needed, images on disk if possible, so that first evaluation can be truly comprehensive and not just sort of a plan for how are we going to get all your records to review in the near future.
Right. So kind of take advantage of that wait period to get all your materials ready. Yeah, right. No, it's some really good points there. I didn't even think about the satellite clinic, and I know that's true for many of the epilepsy centers have satellite clinics, and they have shorter wait times there. So another common complaint that we hear is that patients sometimes end up seeing a fellow or a resident or a nurse practitioner or physician's assistant at some medical appointments, perhaps when they expect to see or want to see their epileptologist. Can you talk about why this is done and address some of the concerns related to that, and also discuss how and when it's reasonable for patients to ask to see their epileptologist?
This is a really important question. I'm glad you brought this up. So unfortunately, I think a lot of this can be pretty opaque. So different training programs are set up quite differently. Clinics are named differently, and it's really hard to tell from, scheduling an appointment in an epilepsy clinic who that means that you're seeing. Now, for the most part, at all of these academic hospitals or hospitals with trainees, and for practices that use non-physician providers as well, such as nurse practitioners or physician assistants, the appointment is typically staffed with an epileptologist, meaning that even if you see a student first, even if you see a nurse practitioner or physician's assistant, as a new patient, you're going to be staffed with an epileptologist. However, I do think sometimes people intend to be scheduled in an epilepsy clinic, and sometimes that gets translated into sort of a chief complaint of epilepsy, but that can be sort of shuttled into a different clinic, and you could end up in a general neurology clinic and be seen by a trainee and not staffed by an epileptologist. So I would just recommend being forward and feeling empowered when you're scheduling the appointment to really ask, will I be seeing an epileptologist? Will I be seeing a trainee? Will I be seeing a nurse practitioner or a physician's assistant? Okay, if I'm seeing a physician's assistant, will they be staffing my visit with an epileptologist? And just try to ask the follow-up questions so that there's no surprises and you know what you're getting into. I have to say, recently as a patient, I made an appointment and was surprised to be seen by a resident. It ends up being fine in that scenario, but just to say, it's not clear sometimes when you're scheduling. Now, I hadn't asked who was going to be seeing me. I should have asked. And I think if you ask, at least you can get that information in advance and then make the decision that you want to make about pursuing that appointment.
Okay. And I imagine at some points, for a routine maintenance sort of appointment, just a regular checkup with nothing in particular has changed or anticipated to change, that, seeing a nurse practitioner, physician's assistant, or someone might be completely appropriate as long as they're, in touch with the epileptologist or sharing, and there's a kind of a team approach. Is that generally the case, for those types of appointments where?
Yes, I agree.
Yeah.
I think that the sort of new assessment is totally different than a follow-up assessment where things are stable. Right. I do have to say that, in my experience, the nurse practitioners in epilepsy are exceedingly expert, and so they do very much know what they're doing, and maybe better than getting a brand new epileptologist, who knows. But I will say that you should also feel empowered as a patient to ask to talk to the epileptologist. That's a totally reasonable question for a physician that's providing care to you. And so, not to say that that has to be an extraordinary situation in which you want to speak to your epileptologist.
Right. Okay, so and this could be a whole topic on its own, but we'll try and do a kind of an overview of this. But out-of-pocket medical expenses are a major barrier to appropriate care and can lead to substantial financial strain. This can include high premiums, deductibles, copays, or coinsurance, and in some cases, complete lack of coverage for a prescribed treatment. So what are the most common challenges you encounter in terms of insurance coverage for epilepsy services and treatments?
This is another great question that's near and dear to my heart. So our group at Michigan has been working on studying out-of-pocket costs for neurology patients in general and specific to epilepsy patients as they relate to drugs and diagnostic procedures and physician visits. And this is becoming a bigger and bigger issue because more patients are having plans with high deductibles. And so we see this cost shifting over time where patients are paying more out of pocket. In the standard practice, when a patient presents with seizures, our initial evaluation is usually EEG and brain MRI, which are typically covered by insurance. I'd be shocked if they weren't. But as you say, the out-of-pocket costs can be substantial. So an evaluation we did, again, using the United Healthcare data, for instance, I'll give you an example from 2016. So we looked at the average out-of-pocket cost for these tests for that patient population, and the average out-of-pocket cost for MRI was $250, and for an EEG was $100. So even these tests that are being covered by insurance that are just standard for evaluation of a patient with seizures, that's a lot to pay out of pocket. So it's truly an issue, and I think we're hoping that we're doing our part with advocacy to improve this for our patients. As far as things that aren't covered by insurance that can be challenging, from time to time I do run into challenges with the studies I order to evaluate bone health. As we know, a lot of our anti-seizure medications increase the risk of osteopenia and osteoporosis, and so I'll order tests such as vitamin D level or a DEXA scan, and sometimes those are surprisingly not covered. So I just try to talk about that, make sure we investigate, the patient investigates in advance before they get those tests done. And then, elective admissions for long-term EEG can be challenging, but most epilepsy centers have a system dedicated to sorting out the insurance before the patient comes in. And then, the obvious challenge is drug prices that are highly variable across insurers and drug plans and depend on a patient's deductible, and that can just be a really frustrating limitation and consideration in planning care for patients with epilepsy.
Right. And I think that's, a key point there that is that, that's where another point where patient empowerment comes in is that, when a patient is being prescribed a medication or a medication being suggested, it's very helpful if the patient advocates for making sure that is actually covered or what are the out-of-pocket expenses going to be, because, we've certainly heard of many cases where someone is put on a medication by their physician and turns out it's either not covered or the out-of-pocket cost is hundreds of dollars per month. So certainly that's something patients can do to, try and avoid those pitfalls.
Yeah, and what drives me crazy in our current system that we need to move towards is sort of transparency of individualized costs, right. Because even though I know this is an issue, my patient knows it's an issue. In real time, we don't know how much a drug is going to cost until we phone in the prescription and run it through insurance. So it can be very frustrating that we can't bring that consideration in real time into the treatment decisions that we're making.
Right. So appealing coverage decisions can be a complex, time-consuming, and frustrating process, and this can discourage people from pursuing a resolution. So what recommendations do you have for when insurance coverage decisions limit access to a recommended service or treatment? And then how do you decide kind of when to fight and when to move on to Plan B?
So I'll talk about this in the context of drug coverage because I feel like that's when it comes up the most. So if we're initiating treatment and we're at a point where there's many options available that seem equivalent at that time, I usually will just start with a drug that's readily covered. If we have more limited options or there's specific reasons that one drug is highly preferred, or if a patient has previously done well on a certain drug and now their insurance has changed, then we'll quickly go to bat for that patient. And my experience is that if we're persistent about an appeal or about working towards a tier exception, it nearly almost always pays off, although it can require a lot of time and energy both from patients and myself and the staff. But persistence typically pays off.
Okay, great. Can you briefly discuss again, this is another huge issue, but briefly discuss the issue of brand name medications versus generics and what kind of systemic changes could be made to address that issue?
So I feel like this is another fraught topic, and I'll tell you my perspective, although I imagine different people will give you different perspectives. So if you look at the literature on this topic, it's somewhat equivocal, but most of the literature supports that when we look at generic drugs versus brand drugs across a population, we don't really see differences. And Lamotrigine is an example of a drug for which this has been studied numerous times, in which across the population we don't typically see differences in efficacy or tolerability, adverse events, or even drug levels between the brand and the generic. Now, I will say there is some quantitative evidence that there can be big variation in the sort of components and levels of drug in across generic formulations, so there may be a bigger difference switching from one generic to another than from brand to generic. I will say that, so I think that the population evidence doesn't make a strong case for brands, and I think that's a fair interpretation of the evidence that exists. Anecdotally, there's ample evidence that for certain patients, the brand seems more effective or better tolerated, and I think in those patients it's absolutely appropriate to prescribe the brand and advocate for the brand. But I will say due to the general lack of difference and the cost savings to patients and to insurers, but largely to patients is what I care about, if there's no prior history, I will always prescribe the generic formulation when initiating a medication.
Yeah, that makes sense. Okay, great. Insurance coverage is often limited for the management of conditions commonly associated with epilepsy, such as depression and anxiety or cognitive impairment. Do you have any suggestions for people who need mental health services or neuropsychological evaluation or cognitive rehabilitation or similar services, but have limited coverage for those?
I have a strong interest in doing better in this area, and I don't have a great answer. It can be so frustrating. The two resources that I'll mention that I think are important not to overlook. So the first is a patient's primary care physician. So I think often I'll see a patient and will diagnose depression, and I start putting in referrals to psychiatry or to psychotherapy, which are great, but those may take many months. Those may or may not pan out. And I have to say, need to remind myself that primary care physicians are very well trained in treating or definitely initiating treatment for mood disorders and are a great place to start in the initial management. And so I think we can't overlook that is a resource in the conversation between a neurologist and a primary care physician for treating mood disorders. As far as another invaluable resource that you and I have talked before about how I feel that it's underutilized and we need to do better, referring patients, are the self-management programs that are available through the Epilepsy Foundation, such as Project Uplift or PACES or many of the very well-developed and evidence-based projects, self-management programs that are in existence.
Right. That's a great point. So I'm actually going to skip ahead a little bit just given the time, and this kind of relates to what you're saying about primary care. So care coordination is another challenge, particularly for complex chronic health conditions like epilepsy, and whether that be coordination between the neurologist and the primary care physician, or coordination during the transition from pediatric to adult care, or with other specialty providers, or between different healthcare systems. Can you just briefly discuss some ways to enhance care coordination so that everyone's on the same page and communicating with each other?
Certainly. So I think as a physician, as a provider, I should always be attentive to this, but often I'm not. I'm distracted by something else. And so well, I know I can and should do better, thoughts about what patients and family members can do. So I think to be proactive in recommending communication with a primary care physician can be very helpful. So, often after the patient's left, I write a letter to the primary care doctor, and I realize, I didn't verify that was still the primary care physician. And so I think just taking an active role, I want to write the letter, and I'm not sure if I have the right person to write it to. I think taking an active role in the visit and saying, Dr. Hill, could you please make sure you follow up with my primary care doctor, Dr. Wallace, that is, everyone appreciates that. That's a great reminder and can clarify who to follow up with, and that can be exceedingly helpful. And then the other thing I'll say is that just making sure that you're enrolled in your patient portal is really helpful, because that can link communications really nicely and can help physicians sort of track what's happening with patients over time in that way as well.
Great, thank you. And lastly, before we open it up for questions, again, we sort of touched on this, but health disparities are numerous in our country, and this is also true among people with epilepsy. So can you talk about some of the health disparities in epilepsy that have been identified and what can be done to address some of these disparities and promote health equity?
Good question. So I think there's some work's been done in this area, but there's certainly a huge need for further work. And I tried to think how to wrap this up very quickly because it's such a massive topic. I will say that there have been several studies that demonstrate disparities in epilepsy care for minority populations. In particular, there's demonstration of delays for a new diagnosis of epilepsy for Black patients. There's some evidence that Black patients are less likely to be referred to see a neurologist and are less likely to receive epilepsy surgery. But this is likely multifactorial, and in the more sort of rigorous analysis, it seems that much of this has to do with socioeconomic factors and geographic factors, although I do think we have to consider that institutional racism is also a component of these disparities that we're seeing with regard to race. There's also great disparities that are seen with regard to insurance status and differential ability to see expert care for those with public versus private insurance.
Right. And I think just, as far as how to address this, we just need to keep studying it, need to keep clarifying what those disparities are and then addressing them through policy and other approaches. So
that's exactly right. I think we're in the early stages of understanding it, and we're still unfortunately several steps away from improving it, although, we can sort of anticipate what those steps may look like.
Okay, so I'm going to go ahead and open it up for questions. Okay, who'd like to get us started with a question?
I've been treated by epilepsy specialists for the past 30 years, and I've been through more than a half dozen surgeries, so I understand very well the need for trying medicines to determine if seizures are refractory, but still, I'm confused. Every time I see another doctor, I have to always wonder why is they want to try one more pill. And in years 2018, I tried number 17 of all the medicines I've tried. Why is it necessary with all the statistics? Why do we have to go through another pill?
That's a great question.
That is such a good question, and something that I'm also thinking about. What's the right thing to do in this scenario? So, you're absolutely right. If we look at statistically for a person like you, and there are many people like you, the likelihood of a medication improving seizures or achieving seizure freedom is quite low. And I think that often, to be perfectly frank, as a physician, we feel that we have to do something. We have to offer something. And for the most part, although the risk of starting a new medication is relatively low, there's certainly risk of side effects. There's certainly the cost. But I think that when we do that risk-benefit assessment, we feel that the risk is reasonably low, but perhaps we're not doing a fair assessment as far as really truly being honest about the likelihood of benefit from that medication. So I agree with you 100% that this is an area in which we need to be really thoughtful about how we can make better decisions and perhaps better shared decision making in the plan to start yet another medication.
Okay.
Great. Okay. Other questions?
I would have one more, if I may.
Okay. No one else is jumping in, so go ahead.
I've been through numerous doctors, and I've had doctors that have acted more like dictators. They know what's right and best, do what I tell you, but then I've seen some that were coaches. Some patients probably need that coach advice, which direction do we go? And then I've enjoyed more the doctors who have treated me more like a team player. And so I'm always trying to foster that team player relationship. Any suggestions how to foster that?
That's another really good question. So, every doctor has a different style. I think I lean heavily on my patients because I don't know how to figure out what's the best thing for my patient without their input. And so I can't imagine coming up with a treatment plan without a team approach, which is just to say, I agree with you 100%. I think that that's a critical way to treat any patient, and particularly a patient with seizures. As far as fostering that, I haven't really thought about that before because I feel like I tend to lean towards that approach. But honestly, what I think could be useful is just sort of saying exactly what you just said when you meet a doctor, and saying, like, this is an approach that's worked really well for me in the past. And I can't imagine how that wouldn't be effective and well received for you to be giving advice to a physician about how to make that a productive relationship. I would appreciate that if you came to see me and told me about what worked well for you in the past.
I sometimes thought maybe at my first appointment I need to interview my doctor and ask them what their approach is and see if you're the appropriate doctor for me.
I don't know how many doctors have great insight into their approach. We think we know what we're doing, like how we're communicating, but it would be interesting to see if people accurately describe their approach.
Right. And another thing to keep in mind is there are materials out there and resources on shared decision making, and if that's kind of the approach that you want, you can kind of come equipped with what shared decision making involves, and you can kind of outline that. And when you're first meeting with a physician, and say, this is kind of what I expect, and this is what works best for me. And I think that would be a completely reasonable and appropriate and helpful approach. So,
okay,
great. We've got a few minutes left. Any other questions or comments?
Yeah, Ross.
Yeah, go ahead.
Greg, how you doing? Well, what do you do if you go to a doctor and they won't get a copy of your records or from one that you're going to? A couple of years ago, I went up to Flint, Michigan to see a friend of mine. I went to a doctor over there, and the first thing that he wanted to do was, was put me on Topamax. Or he wouldn't even get a copy of my records from my doctor in St. Joe.
Yeah, I mean, I definitely think if you're seeing a physician who is not familiar with your history or your case or your and does not have access to your medical records, they likely should not be making changes to your treatment regimen. Is that, or Dr. Hill, would you agree with that?
Yeah, and just to clarify a little bit, is that a medication that you tried before, or is that what was your concern?
That's he put me on Topamax, and I tried it, and I got weak from the stuff. So I didn't take it, and I called back and scrapped the appointment with him again.
Yeah, so I think if you ever feel like you're rushing into a treatment decision, you absolutely should feel comfortable saying, before we decide this, let's make sure you have time to review what I've been on previously, what I've tried previously. I think that's totally reasonable and totally appropriate.
Okay, thanks.
Okay. Other questions? Got a couple of minutes left.
Yeah. Hi, Russ.
Hi, Karen.
Good morning. I sponsor a few people with epilepsy, as Russ knows, and I've got a couple right now that their neurologist is like trying to take one off of Keppra and put her on Briviac, and now within 2 days she wants to go back on Keppra and stuff. And a lot of the people I talk to don't want to give it the full month of a try. And the doctors are getting upset. What can I do to calm them down and, to continue taking the medications to see if they work?
So I apologize. I just want to make sure I understand. So if the patient doesn't want to give it a full month of try?
Correct. Like one girl I sponsor, she's had surgeries and stuff, but she's got other medical conditions. And her neurologist put her on, well, she was on Keppra, put her on Briviac. She doesn't like it after 2 or 3 days, and she wants to go right back on Keppra.
So I think it probably depends on why she doesn't like it. So I think if there's some side effects that may warrant switching back quickly if she has those, versus there's some side effects where we think that they could it get better with time and it may be worth a longer trial. I think I don't mean to evade your question, but I think without knowing more of the specifics, it's hard for me to tell you exactly what to do. I can give you an example. So some seizure medications can actually lead to people feeling super depressed or suicidal, and that's not the kind of thing we would want to wait out for a month. Whereas starting a new medication and feeling more fatigued or tired is something that may improve after a week or two.
Okay, yeah, because she's paralyzed on her left side, so she's very depressed.
So I would talk to your doctor specifically about what's been bothering her over the past 3 days to make a decision about if it makes sense to continue or not.
Okay.
All right. Well, it is 1:30, so I will go ahead and wrap it up. And Dr. Hill, thank you so much for a really fascinating and in-depth conversation on a very complex topic. So I really appreciate you taking on this challenging topic and helping to shed light on it. So, and thank you everyone for participating today. If people do have any questions, please feel free to contact us at 1-800-377-6226 or visit our website at epilepsymichigan.org. So thank you again, Dr. Hill, and thank you everyone for participating.
Thank you very much. It was a pleasure speaking with all of you.
You too.